both have their place, of course, in the treatment of aneurysms, and I'll change it from coiling and clipping to endovascular treatment versus cerebrovascular surgery. Initially, when I was training, endovascular was early on was kind of newer. The reason why I went into vascular neurosurgery was not for the endovascular side, but for the open vascular surgery to do things like this. And seeing the future, we all knew that it was going to go towards endovascular. At least that was an important, it would be an important adjunct to training, and so I got that training in endovascular. It was always a question, can you do both? Should you do both? At that time, that was a debate. I think that debate has really been settled as to, regardless of what you think the big fish is, it's certainly, there's a generation of neurosurgeons my age and younger who certainly I think can do both. But a decision for which way to proceed with the patient is really based on the patient population, with a lot of great work being done on ruptured patients. And the location also plays a significant factor, anterior versus posterior circulation, with specific locations having different consequences. Basilar apex being going in favor of endovascular, and MCA bifurcation continues to be an area where there are ongoing soirees from different endovascular techniques, which have continued to be sort of fraught with peril, and I think really do not meet the bar for treatment and beating the natural history with open surgery or with endovascular treatment for that location. A very significant component is patient preference in this era of shared decision making. That is something that is very, very important, and that has its pros and cons. And then technological advancements, as we all know, is really is a main driver in these decisions and what the opportunities are for patients. Most importantly, the comfort level of the surgeon. I think this is the lens through which we advise the patient, and that's really where the comfort level of the surgeon should be really on both sides. If a surgeon can only do one thing, endovascular, they should have a good open surgical partner. And that is something that I think really, unfortunately, is going by the wayside for what people see as a settled debate, as that in all locations, for all patients, in all situations, that endovascular is better, and that's really not the case. So if we go with the ruptured aneurysms, this has been, I think, we have the best data for this with the ISAT trial with Andy Molyneux and colleagues in Europe, and some in the United States, showing that absolute risk reduction was 7.4%. In the Barrow ruptured aneurysm trial in the US, we have a absolute reduction with endovascular treatment for these ruptured patients of 15.5% in the actual treatment arm. There was noted a high crossover from clip to coil of 37%. So that's notable because, over 1/3 of patients were initially deemed to be suitable for both treatments. And then ultimately it was decided at some point prior to their actual treatment that, hey, in fact, we cannot treat this endovascularly, and they should instead be treated with surgery. That patient cohort did not fare worse than the patients who were initially assigned for clipping. They fared about the same, which was overall, quote unquote, worse than what the endovascular patient's outcome was. In that third of patients, however, there was not truly equipoise, and that they sort of failed endovascular treatment. So this trial, in my opinion, having trained there, of course, done by great people, Dr. Spetzler and McDougall and Albuquerque, with whom I did fellowships, I'd say that this is the best cohort in the world to do this surgery. And these are the results, which basically say if you can treat it endovascularly, the patients would fare better. But if you cannot, then clipping, of course, is a great alternative. There's a lot made about late rebleeding on the open surgery side. And if we look at the complete occlusion rates on the left-hand side here, they were much lower in the endovascular treated group, only 66% achieving complete occlusion. And in the microsurgery group, 82% of those achieved complete occlusion. However, if we look at the likelihood of those patients having rebleeding during their first year, they were really quite similar. This durability was published in the almost 18-year follow-up of the ISAT trial, showing that patients who were treated endovascularly had a lower death and dependency rate with endovascular treatment, and independence was similar but lower in the endovascular group. The overall risk reduction, importantly in ISAT, was 7%, not 77%. And this really changed how things were done, despite a very small difference in the absolute risk reduction. If we look at the rebleed and this long follow-up, there were more rebleeds on the endovascular side, but not by a large number, by a few patients, and that rebleeding was not statistically significant between the groups. In the unruptured aneurysm clipping side, if we look at those patients and their long-term follow-up, this is a well-done study which looked at meta-analysis and looked at morbidity and mortality. And what you can see here is a very low mortality with clipping, very low morbidity with clipping. However, if you look at these funnel plots of mortality and morbidity, you can see these asymmetry at the base here with the standard errors indicating significant bias in these publications favoring better outcomes. So it really hampered on the open surgery side with bias in how these results are reported, and that's unfortunate. If we look at the follow-up ISAT-2 prospective study, it was powered for, and this compared open surgery versus endovascular treatment. It would have been a very important study. However, it was powered for 260 patients after a very slow accrual, which was tapering off. Only 136 patients were actually ended up being randomized and treated. So there was no significant difference in morbidity at 1 year. Since my colleague is not here, I will just continue proceeding for another 5 minutes or so, if that's okay, if the moderator's
Yeah, that should be fine. That
okay,
should be
thank
fine.
you. So if we look at endovascular unruptured aneurysm treatments, there's coiling, and this is a moving target in that the coils and the endovascular techniques continue to evolve given the significant infusion of not only manpower and energy, but also the industry, highly patentable devices. We can look at primary coiling trials on the top here, or registries, stenting with balloon-assisted coiling. You can see that sometimes the complication rates are quite high, 10.3% versus 9.3%, and this is for stenting 10.3 and balloon-assisted coiling 9.3%. And much of this morbidity is due to middle cerebral artery aneurysm coiling, middle cerebral artery aneurysm coiling. This is an area where we've known for a long time that MCA aneurysms have a much higher risk of treatment with endovascular techniques. However, people continue to push on, which is very, very frustrating to see. Unfortunately, the all or none sort of a treatment paradigm. The PUFS trial, a pipeline device, really was a game changer. And if you look at the 3% occlusion rate for patients who were not candidates for other endovascular treatment paradigms, there's a very high over 93% occlusion rate. In some of those, 5 patients required retreatment, only 0 recanalized. Some of these patients certainly were candidates for open surgery, but this is certainly a very powerful technique for certain patients. Now we have various intrasaccular occlusion devices like the Webb device, demonstrating low complete occlusion rates. 84.6% were deemed adequately occluded, and importantly, the hemorrhage rate still, however, is quite low. So I think that is the important point here, is that the retreatments do not carry this significant morbidity that has been sort of oftentimes overstated. However, with endovascular, importantly, even despite the paradigm shift, there are still issues. This is a patient who came in with standard subarachnoid hemorrhage, has an aneurysm, A1 segment, kind of an unusual location, middle of the A1, no contralateral A1. This was treated endovascular, as you can see here, with still some filling in the dome, but due to the wide neck, was not pushed further. Within 6 months, the patient presented, unfortunately, with progressive visual loss, which we evaluated with MRI. And you can see here that the patient has significant compression from this thrombosed aneurysm with the coils being pushed way up and recurrence at the base. Despite attempts to be able to clip this patient, the family and the wife were quite scared of this. Again, that shared decision making coming to bear, and therefore we treated this with the Elvis stent and recoiling, and we'll see how he does, but that would not have been my preference. But I did not have the option, given that the family would not allow me to treat them open surgically. So do additional treatments for recanalized aneurysms increase lifetime risk significantly? I think we have these one-off cases. However, if we look at larger series, this one from France, they would say that in 4 centers, a lot of patients, a lot of 20,000 of patient years, 28 rehemorrhaged in that time, so a very small number, less than a little more than 0.5%. And many more were retreated without rehemorrhage, almost 5%. So the morbidity of that retreatment tends to be quite low, and therefore this philosophy of endovascular retreatment being a very concerning thing is, I think, really overstated. It's similar to this, where you have to first pass that initial hurdle of treating the patient with their initial problem. And if you focus on the second gate here, you might stumble on the first decision, which would be the higher risk treatment potentially. Here's another patient, which I think highlights the importance of combined techniques. Is a patient who came in with this aneurysm, which is a sidewall aneurysm coming off the carotid at the communicating segment here, and also an ophthalmic segment aneurysm. Initially, this patient, due to her young age, was treated with clipping, as you can see here, with, I think, a good result. However, within 1 year, she pooched out these new aneurysms, ICA terminus, A1 segment that you can see here, and just distal to the clip. So it's really quite surprising to happen within 1 year. We do not have a solution for this with open surgery. It's really where reconstructive techniques with flow diverters, after clipping, you can see a flow diverter in the A1 segment here, followed by another flow diverter jailing off the A1 segment in order to achieve a good reconstruction with an intact patient. So really, the other very important point here is, what do patients want? Despite attempts at trying to guide patients gently but sternly towards a certain treatment, they may choose one way or the other that we think may have a slightly higher risk, maybe not unacceptably high, but higher than we would like. And that happens both ways. Here in the Midwest, we have farmers who say, I want to get my aneurysm treated, never have to worry about it again. They want it to be clipped. And the younger patients are potentially more risk averse, and they equate that risk of treatment with recovery time. And so therefore they may opt for, or really push hard for, an endovascular technique. However, ultimately, I think that this ship has sailed on this conversation of which one is better. Really, there's important drivers, and there's been a paradigm shift. If we look at what is being done now in the U.S. and overall, about 2/3 of aneurysms are now being treated endovascularly, only 1/3 being treated with open surgery. And this is a National Inpatient Sample database. If you look at the Helsinki experience, it's even more dramatic, 70% at a center, very skilled operators, 70% being treated now endovascularly. Really, I think that it's shifted to a point where now we have expert groups for open microsurgery to lend their expertise and try to continue to do this. So really, innovation has really fueled the push for newer endovascular devices, robotics, AI. All of this will continue to push endovascular techniques further and further. And we can see all these new devices that are coming out. These are not theoretical devices in the top left, but those that exist currently. In addition to flow diverters, AI techniques showing us how well opposed devices are, and better understanding of antiplatelet agents for these devices, and soon to be robotics for endovascular, which will allow endovascular specialists to really extend their reach much further than was historically thought. So the pendulum has swung perhaps too far, depending on who you believe and who you follow. However, I'd like to see that patients be treated appropriately, and that people have honesty with regards to the risks of treatment. Middle cerebral, and based on this analysis of recanalization of endovascular treatment, we can see patients who are higher risk for endovascular treatment, those who smoke, those with ruptured aneurysms, larger size, wider neck, middle cerebral artery location. All of these are also potential risk factors for open surgery as well. So I think our primary focus should be on safety, the safety for the patient, not for the proceduralist. Really, if the skills are not present in one person, then they should work with a skilled colleague and be honest and forthright regarding the best way of treating that patient, which is the lowest risk option. Not just what can I do, what do I have available in my skill set, but what should be done for the patient. A recovery time is a secondary consideration. You know, what is a couple of weeks or a month in the life of a patient. Exposing them to a higher risk treatment is, I think, inappropriate. So ruptured aneurysm are better treated overall endovascular as a first step, a default. However, many patients will not be amenable to that form of treatment, and therefore we have to maintain our open surgical skills in order to be able to offer that to patients. And there's site-specific considerations and wishes of the patient should be primarily considered when there's equipoise for treatment. So with that, I'll conclude. I don't really think it's much of a debate between the two. I think really these have their own place in therapy. And despite newer techniques and all the infusion of energy from industry and money that's involved, I think there will continue to be a place for both if we're honest with our results. And if we even look at the published data, we can see that if a microsurgeon published 10% complication rates for their techniques, they would be laughed off the stage. However, that's allowed in endovascular arenas because of in my opinion, the money that's involved in this. So with that, I'll conclude and thank you for your attention.
Thank you
Thanks,
very much.
Azam.
Thank you very much.
Something here.
There's been one question that's been posed, and that's about your thoughts on the best timing for intervention, whether it's surgical, particularly surgical, but also for coiling. What's your thoughts on that? And I think that there are people on the webinar who are keen to know your thoughts on the timing of these interventions.
May I ask something? Me?
Yes.
There is one point that what's happened with the patients that you are treated in the past with coil, with matrix, is coming every day a new device. See? And you believe the web, for example, the web that now is advertising around the world how the solution to everything. They have 52% of complete occlusion. Should be not out of the marketing, because if you have an aneurysm, just 53% is occlude. It means the aneurysm is still open. You are going back to the natural history or unruptured aneurysm.
Yeah.
90% is 100%.
Yeah. So with regards to the first question regarding the timing of surgery, I think for ruptured aneurysms, that is, quite well settled that the patient should be treated ideally early to prevent rebleeding. Rebleeding rates are up to 50% at 1 month, depending on the case series that's followed or the data that you look at. There's various ways of looking at that. Obviously, prospectively, retrospectively, have good data on that. The technique of treatment, I think, has to be able to meet the patient where the demand is. So if we know that patients rebleed if they're not treated, if they present with hemorrhage initially, and so treating those patients, whether it's with endovascular techniques or open surgery, the aneurysm needs to be secured. And to Dr. Borba's point, I think that occlusion should be something that allows the patient to prevent bleeding. Now, when we look at aneurysm occlusion rates, obviously complete occlusion is a great goal, but really what we're trying to prevent is rebleeding. In some cases, incomplete occlusion endovascularly, as many of the series show, do not result in rebleeding. So the fist pounding of, well, the aneurysm is not completely occluded, the large series would not indicate that is problematic over the short term. Okay, I'm making a distinction here. This is not something that the patient should live with for their life. If that patient if we go in and we put one small coil in a large aneurysm, that does nothing to help the patient. We'd all agree with that, probably does very little. On the flip side, putting in many coils, achieving a packing density that's over 30% with a little bit of residual filling in the aneurysm at the conclusion of the case, I would argue is an adequate result at that time and most often goes on to completely occlude. That is not the intent when the patient is initially treated endovascularly, but that sometimes is the result, and there's a trade-off with that. Now, I feel like I'm pretty balanced. I treat 50% of patients endovascularly, approximately my series, and I treat 50% of patients with open surgery. And I think that that allows for an appropriate balance of the two procedures and to treat the patient in the appropriate context.
Can I make a comment, please?
No, but I'll ask you something. If you have a device that occludes 53% of the aneurysm, it's good?
No, I don't think that that's good.
Why is it still in the market?
I think that there's two different scenarios. One is that you've put a device in the dome where we all know the aneurysm ruptures from is still filling. It's still filling aggressively. You can see that. That is one scenario. The other scenario is an aneurysm that is, like, again, packed to over 30% packing density, where there is some filling in the dome, still a Raymond 3, right? But that is a very different situation. So with regards to the web device, the filling in the dome of those patients, many of those will go on to completely occlude, leaving patients, and I think that without and that experience took time to develop. I'm not a great proponent of web. I've put in many of those, but I'm not a big proponent of it for a number of other reasons. But I don't think that the initial aneurysm occlusion rate is indicative of, and the literature bear this out as well, of a high rebleeding rate. Okay, so that's an important point, is that despite the low initial occlusion rates, even out to 6 months, many of those patients will continue to go on to occlude.
Okay, can I just make a comment? Yeah, it's unfortunate that there is nobody to defend microsurgery, but very great talk, Ahmed. Dr. Ahmed, it was a balanced talk. I appreciate that. But a couple of comments I would like to make. Number one, I wish I had given this debate rather than the robots, which I have no knowledge about. But anyway, so the number one is ISAT being, kind of taken in out of context. ISAT was only small aneurysms, grade 1 to 7.